which which in and of itself is not a bad thing, to seek mental health support when you're not feeling well. But to completely relegate somebody to the area of, okay, you have a mental health issue, you do not actually have a physical condition, is a very dismissive sort of thing that happens. And very often the person feels, not only do they feel let down, but they also feel dismissed and discarded by the system. And we know through our experience that chronic pain is a very real thing. And I will say that even with the vast advancements we have made in science, there is still a lot that we don't know. And I'm sure in the years to come, we're going to discover things about medical science that are still not within our understanding. So the thing also is that illness will impact the disease. If I have cancer, I start feeling ill, I start feeling anxious, I start feeling stressed. I go for numerous investigations. Just going to the hospital makes me feel tension and panic. I don't want to go to the hospital, so I'll start being non-compliant as a patient. And as a result of that, I'm not actually looking after myself in the way that is prescribed. My emotions and discomfort and insomnia could lead to further fatigue. It could lead to further uh, weakening of the immune system. My body is not able to fight back as effectively. And then that becomes a vicious cycle. So disease and illness, they go hand in hand. Sometimes they're sort of disconnected from one another, but by and large, this is the difference. Okay. Yeah. And our job is to address the disease and the illness. And that is part of the whole holistic approach in palliative care. Now, why is psychosocial care important in palliative care? Because firstly, living with a life-limiting or a life-threatening illness. Now, I just want to make the distinction. Life-threatening is a disease that can actually cause termination of life. It can cause death. Life-limiting is something that people can live with for many, many years. It could be it could be a spinal cord trauma. It could be a stroke that has caused limitations after that. It could be a disability in some cases. So those are also life-limiting conditions, which does not allow us to engage fully with our surroundings and activities of daily living and so on and so forth. So living with any of these conditions or the awareness of approaching death in a terminal condition causes unique stressors and challenges. Can you tell me what are some of these unique stressors and challenges that show up at these times, which are usually not there when you're not living with a life-limiting or a life-threatening condition? What are some of these unique challenges? What are some things that some stressors, psychosocial stressors that show up at this time in life? The rush to deal with things before impending death, yes. That is provided you know that it's impending death. What else? Financial planning, decision making, yes. Not being able to keep routine, yeah. Isolation, excellent responses. Excellent responses. Low self-image, sense of failure, helplessness. Yes. So these are things. And also worry about the family. Losing control of your life. Now the disease determines how your day is going to go. Someone said loss of routine. What will happen to the people that are dependent, burden, feeling a lack of meaning, guilt, anxiety about death itself? Yes. Okay, fantastic. You guys have populated the chat box with all the possible answers. Those are all the unique challenges that people face. And a serious illness disrupts an individual's thoughts and feelings, relationships, social and spiritual supports, financial stability, and spirituality. So every aspect of being a person is disrupted by the disease. Everything. And you folks have already talked about it. Feeling like a sense of burden, no meaning, meaninglessness. These are all other spiritual aspects as well, and the deeply personal aspects to our existence. And all of that is, it is derailed and disrupted by a serious illness. Okay. So coming to the crux of why we're here, assessment. in order to be able to help somebody, you need to be able to assess accurately what they're struggling with. And it's really an exploration process. It's not a once done and dusted. No, it is an exploration process, gathering information, and how you choose to support somebody will depend on what is being assessed. What does this mean? The selection of goals and interventions depends largely on what is being assessed. I'm going to stop sharing my screen for a second so I can see everybody's faces. What does that sentence mean? How you support somebody depends on what is being assessed. Can you give me an example?
I think if you were to just assess someone as based on their disease, then you will only try to treat that, like your only goals are symptom management, and like it's very limited. Versus when you start looking at psychosocial factors, you might be able to help them a lot more. I think an example would be, I think it's really simple when we write out case studies. I was thinking of this. Sometimes when doctors and nurses have to write out case studies for efficiency, they will write out patient 34, you know, decreased breathing, whatever. Just it's just a list of lack of things, just their deficits in terms of physical inability, and it doesn't point out the person's entire life, which can change their
That's
goal.
a fabulous example. Thank you. Thank you, Narmada. I can see that people have also started writing in the chat box. Ask what the patient needs, desires, and that can become one of your goals. Yeah. How often? I mean, I think that lines up with what Narmada is also talking about. If we only focus on the disease and not on what the patient needs or wants from us, then our focus is only going to be there. And ultimately, you have an unsatisfactory relationship in that sense. Specific goals could be what exactly is the person stressed about. Could be about children. Yes. How is it affecting the person's life? Physical conditions, emotions. Okay. Yes. So a simple thing is, for instance, as a doctor, I might go and say, what's bothering you? Person will say, I'm in pain. And also, I'm having a really hard time sleeping. My thoughts keep me awake every night. I will deal with the pain because I can give medicines for it. I may not be comfortable going into what are your thoughts at night that keep you up? Because one, I may not have the time. Two, I don't have the inclination. Three, I don't have the adequate skills to sit with somebody and process those things. So very conveniently, I will treat what I can treat and I'll say I've done my job and I leave. But in that case, it also biases what I assess. So the next time, instead of saying what is bothering you, I'll say, are you in pain? So because I'm only narrowing my perspective to what I can treat. I don't even want to ask open-ended questions because I don't want to go there. So that's what I mean by what is being assessed will determine the goals. If you then have the ability to sit with somebody and say, okay, let's talk about what's bothering you. My children's education, my wife's well-being, my brother who lives in the next state, I want him to come across, those kind of things, then the goals will shift accordingly. A classic example is in end-of-life care. What is important to you right now? For some people, it might be, I don't want to be in the hospital, I want to be at home. So all the goals and interventions then will be towards that. If I don't ask that question, I will just assume that the best care that can be given is in the ICU. Right? So I think what's important for all of us as practitioners now is to examine the questions we ask. What is that question serving? Is it serving the needs of the patient in front of me? Or is it serving my own needs, depending on my comfort level, my energy levels? I've had a really long week. My God, I don't know if I can deal with one more shared decision-making conversation. So I will keep it crisp. And I feel like I'm helping, but I'm not going to do some major heavy lifting right now. Okay. Aparna, you say that even in my experience, when patients are asked what is bothering you, even patients think they're being asked for physical symptoms. Yeah, because that's historically the way the healthcare system has worked. And as a psychologist, you have to probe a lot more. Often, patients will also give answers that they think the doctors want to hear. That also happens. There is that once every now and then that happens. You want the doctor to approve of you. You want to be the star patient that is being responsive. You want to be the not difficult patient, right? So all of that. So let's be mindful of the kind of questions we ask our patients and their families. What is it that we really want to assess? Now, inaccurate or incomplete assessment will lead to inappropriate goals and interventions. There is no two ways around it. Inaccurate or incomplete assessment will lead to inappropriate goals and interventions. You will end up giving the person what you think they need, not what they need. Now, sources of information for assessment: the patient itself, the patient's caregiver, collateral sources like friends, relatives, neighbors, and those neighbors and relatives can be accessed when you do home visits. And that's pretty much a cornerstone of community-based palliative care service delivery. That is a source of collateral, I mean, that is a source of information, collateral sources. And home visits. What can you learn? What can you learn by visiting someone's house that you can't learn otherwise? What can you learn by visiting someone's house that you can't learn sitting in your clinic? You can unmute and speak up if you like. Home
I
environment.
think
Yeah, Shala, please.
I think when you visit someone's home, you'd better be able to understand their financial status by the quality of life that they live at the home. You would be able to sort of determine the relationships that they have with their spouses or other family members. So I know for us, we are able to determine their income status by the home. So you'd be able to really know if they can't afford care, if they're struggling, if they're going through a lot of financial suffering and stuff like that.
Absolutely. I can see a lot of other inputs as well. Hygiene, monetary status, one-to-one interaction. You can tell how many people are living under one roof, whether the person has ventilation at home. I've been to patients' houses who have respiratory disorders, and they are staying in a house where there is cooking happening in the same room on a wooden stove with no ventilation in the room. Or you realize, if you remember in our introduction session, I told you a story about that boy where we put in the parallel bars. You know why he's not coming for physiotherapy? It's because he can't. And so that's why we need to go home. That's why we need to set up those parallel bars. So home visits, I know not everybody can do it. Okay. But so what we're talking about now is idealistic, optimistic. So by and large, if you're able to visit somebody in their home by invitation, please do it, because that'll tell you a lot more about what they're coping with than what we think. A simple example also was I was working with a boy with juvenile rheumatoid arthritis. He had transitioned into a wheelchair. His mother had been carrying him all that while he was 12 years old. And then his mother had finally he transitioned to a wheelchair. And we thought we were doing him a great service, and the mother, till I went to his house. And I realized that the toilet is 30 feet from the house. And there are stairs. I've gone to other people's houses where the wheelchair is just sitting under the coconut tree. They use it to dry stuff on. It's used as a clothes horse. So we think we've done a great job by donating a wheelchair to somebody. They don't even have a paved path. So those resources can then be reallocated to somebody who needs those. And what do these people need? We'll know better. All right. We also get to understand if the patient has a voice at home. Shalaka, that is such an important point. Not just the patient, the caregiver. 80% of caregivers around the world are women, usually the most disempowered woman in the house. She is the one who's doing all the bedside work, changing, dressings, cleaning, all of that. Does she have a say in the decisions of care? No, she's just there to implement. Bathe the person, clean them up, change their diaper, all of that. That is the stark reality around the world. It'll be the youngest bahu, daughter-in-law, who's just come into the house through marriage, arranged marriage, never spent time with this family, and boom, somebody is sick. She has to drop everything. I'm sorry if you had hopes for to go out and work or something. Sorry, your job now is to stay at home and look after your elderly father-in-law. Does that woman have a voice or agency? No. Usually, I mean, we'll come to that. So that's a very important point. Do they have a voice? Because the caregiver will accompany the patient to my clinic. I will give them a list of things I want. Let them eat this, let them do this, let them do this. Theek hai, theek hai, theek hai. And they go home. She'll just be shut down. She's talked over, or the patient is told, no, we will handle you the way we've been handling you. So that's a very important point, whether the person has a voice in their own household. Okay. Now, assessment is an ongoing process. Okay. Like I said, it's not over and done with in the beginning. And as psychosocial needs of the patients and family and caregivers change over the course of the illness, how will it change? A person who is sick suddenly loses mobility. That's a huge change, right? So somebody who was able to be independent and at least take care of their day-to-day activities now is dependent on the person for bathing, for moving, for transferring, for toileting, all those. So there's a change. Now, what is the assessment? Now, what is the impact on the person and the family? It could be that their living condition has changed. They can no longer afford rent. So they've had to move further away, or they've had to move to a different place, right? It could be various things. So as if it is a terminal illness, as the person becomes more weak, as they are actively dying, as they're in terminal stages, and then of course the death and then the bereavement, changes happen across all these breakpoints. We call them breakpoints. So it's not just when a person starts dying, it's along the way. Okay. And which is why purposeful observation and purposeful conversations are so necessary. Sometimes I've heard people say, yeah, I sat with the patient and the family and I helped them ventilate their feelings. And my question then is, what did that look like? What is ventilation of feelings means? It doesn't mean you're just sitting. Psychologists here know that. It has to be purposeful. The questions you ask have to lead to a certain point. You can't just say, tell me how you feel. And then they say what they have to say. At the end of the conversation, they've poured their heart out to you. You have nothing that you can do with that information. Saying stuff like, call me anytime. Is it purposeful? Is it helpful? What if they call you at 11 o'clock at night? You're not going to be very helpful at 11 p.m. or 3 a.m. And you certainly are resentful that they've called you. You cannot be of help. So it is not purposeful. It is not helpful to say, call me anytime. Give them specifics. It's good for that person also to not have to worry about, is it too late? Is it too early? You've said, call me between 12 and 5 during the day and I'll be available. Make yourself available. So those kind of things. Purposeful observation. Again, I can only speak to the psychologists here because that's been my training. But we are taught to observe very specific things, whether it's the body language, whether it's the mental status, things like that. So similarly, there are certain things that you'll purposefully observe, right? And why you're doing that is because in your experience, when these things don't line up, then the person is likely to have other issues. Okay. Lack of purpose in those conversations actually feels like betrayal. Yeah. Because once the patient vents and we have nothing to give, they end up feeling like there's no point. And what also happens, Aparna, that's a very good point, is that several people will go thinking they're being friendly, they're being helpful. And this person is just tired of telling their story. What has come of it? Nothing. So ask the questions that you can specifically help with. Be purposeful in your observations. See make sure what you're observing actually translates to setting goals. Okay, so that's one part of assessment that is absolutely vital. And this becomes a skill that we can build on and cultivate as our practice continues. Okay, so now Ramu has come to you. And we talked about total pain, right? Total pain is life circumstances, socioeconomic, spiritual, psychological, and physical. Now, Ramu has come to you. He has been shunted around. He's lost all his money. Finally, either somebody tells him that, yeah, there are these people who do palliative care, or he discovers it through other means. He comes to you. What are you going to assess about Ramu now? Firdaus, I will come back to purposeful questioning in our communications class, if that's okay. We'll go in depth into purposeful questioning if you can wait for that. Yeah. Okay. Ramu has come to you. In fact, I think you will get some purposeful questioning examples right now. Does Ramu have an accurate picture of his diagnosis and prognosis? Why do you want to know that, Narmada?
Hi, I'm just gonna answer. I think, especially with prognosis, I think it'll help him have more autonomy on his medical decisions, on how much treatment and intervention he wants. For someone like Ramo who is financially burdened, it will help him understand what he needs to lay up in order to make those decisions. He will, if this is life-threatening, then Ramo will also want to make decisions about resolving relationships with his children, which Ramo has. He'll want time with his family. If he's shunted from hospital to hospital, which will continue to happen if it's just treatment oriented, as in like ICU, ending up in the that's yeah.
If he knows that it is life-threatening and possibly not too far down the line, priorities will change. And perhaps then if priorities change, obviously the goals will change and how you can help will change. If somebody is in denial of their prognosis or diagnosis, then your energy is going there. That collusion, so your goals also pivot along with where that person is. So excellent. Yes, you want to know where he is in his understanding of the diagnosis and prognosis. Do a case study of his disease and the course of treatment. When you say do a case study of his disease and course of treatment, is this with him or is this with his previous healthcare providers? Who are we doing this case study with, Anita? Okay. What he would like to deal with first, his priorities. Okay. Fine. Remember total pain with his previous healthcare providers. Okay. That is an important aspect of gathering information, Anita. I absolutely agree with you. At some point, that has to then become participatory with him. Otherwise, it becomes, again, a bunch of people making decisions about him. So what you said is absolutely right. Do that data gathering and information gathering from his healthcare providers who were previously in charge. And now with this information, work with him. Now, remember the 4 quadrants also. Is there anything you want to know about his physical condition? Is there anything you want to know about his emotional state? Is there anything you want to know about his socioeconomic condition? Is there anything you want to know about where he is feeling existentially and spiritually? So anyway, just think about those. You can put that in the chat box if any question comes to you. But those are, okay, so he's come to me for the first time. I'm thinking of total pain. I have to consider all these different aspects. But before that, remember, I need to find out who Ramu is. Who is Ramu? And how do I find out who Ramu is? I am going to do a couple of things, okay? Well, more than a couple of things. I'm going to understand his and his family's overview. Who is in his family? Where do they come from? What is his understanding and their understanding of the illness? Like Narmada said, family structure and dynamics. I want to know who is in the family and how they communicate with each other. Socioeconomic status, because I need to know what is his financial condition. Because his financial condition will also tell me what treatment options are available to him. Okay. Psychological state. If Ramu is completely distressed, he's not going to be able to make any clear-headed decisions. So I need to understand what his psychological status is. Is he depressed? Is he anxious? Is he grieving? What is his psychological state? Does he have any spiritual distress? Why has God abandoned me? There's no meaning anymore. Maybe I should just end my life so that my family can have a better life. Sorry, am I okay? Can you all hear me okay? All right, fine. And psychosocial issues. This is not always warranted, but when there is an intimate partner involved, this is very important for the partner's well-being. Very often, disease will take away sexual intimacy. And that has an impact. And we are very, we don't like to talk about it in India, but this is something that we need to build the skill to talk about. And then finally, after figuring all these things out, I need to come up with interventions and plans. And it's not that I have to go through all of them. The interventions and plans will keep changing as Ramu trusts me more, starts giving me more information. I cannot hope to get all of this at one shot. There's a certain amount of rapport building that has to happen. But when you sit with a patient, I'll tell you this from my experience, when you sit with a patient and really ask them about themselves, that in and of itself is a rapport building exercise. Because very, very often we find that, especially like, Namrata said earlier, or someone said earlier, they become a case file number. We have this terrible word for caregivers. We call them bystanders. Have you heard that phrase? Bystanders? In hospitals, they call bystanders. Have people heard it? Give me a thumbs up or something if you've heard this phrase, bystander. Yeah. To me, it should be eradicated from healthcare, because a bystander, by definition, is someone who stands by and watches. Whereas a caregiver is really somebody who's in the ring fighting with you and really doing all the heavy lifting in terms of making decisions, care, bathing you, cleaning you, doing your bank work, helping you out with everything. And really, yes, it's not almost, it's extremely insulting. So I remember we've had cases where we've sat down with patients and said, tell me what this journey has been like for you. Where did you go? What did you do? What medicines did you try? What worked? What didn't work? Who's in your family? And then you ask the caregiver's name, and the caregiver is shocked because it's the first time someone has asked them their name. You have won the trust of the family if you can go that far with them. That is your first step in earning somebody's trust. And so often, patients are invisible in the healthcare system, and caregivers are even more invisible. So if you start treating them like a person, that is the first step in gaining their trust. And then as we go along, we will start setting goals and interventions. Okay. Now, let's take it little by little. I'll try and be quick about it. Patient and family overview. What do I want to know? I want to know their demographic details. I want to know their occupation before and after the illness. It's a very big part of what makes up my personhood. Who are you? I'm a psychologist. I'm a social worker. I'm a hospital administrator. I'm a carer. I'm a mother. I'm a father, all of that. But a lot of it is tied up with occupation. And now that you don't have the occupation that you had earlier, how are you managing one, firstly, financially? Secondly, what does that make you feel about yourself? Okay. Who is the primary caregiver and what is the relationship? Please understand the primary caregiver may not be the one that is most emotionally close. It is the one who can perform the duty. So it is not to be assumed that the primary caregiver is the one that is closest emotionally to the person. The person who is emotionally closest may be in a different city. Okay. But when I mean primary caregiver, I mean who is the person by the bedside doing all the work. It's very important. And who is that person? What is that person's role in the larger family? Are they just treated like a minion, or do they actually have some respect that is given to them? Are they given decision-making capacity? All of those things, okay? Now, insight of the patient and the caregiver, what do they have about the diagnosis, prognosis, and palliative care? This is something that we already just discussed with Narmada. How much do they know about their illness? Do they know they have an illness? Okay. Do they know what the prognosis is? Do they know why they've been referred to you? Now, this is make or break, guys, because this is very, very essential. This will set the tone of a lot of the care that you're going to provide. So I remember when I was working in a major cancer hospital, a government cancer hospital, it was my first week. I think I was 23, 24 years old. And I was overwhelmed because I was in the children's department. And I came outside during my tea break and I was sitting there. And this gentleman came to me and he looked at me. He says, "You work here?" I said, "Yes." And he came up with a piece of paper and he said, "Where is this place?" And the piece of paper had the name of a hospice written on it. So I said, "Oh, this is in this part of town." And he said, "Is it a good hospital?" I said, "It's not a hospital, it's a hospice." So he said, "What is that?" So I said, "It's where they take care of pain and, symptom control and stuff." And I was also young, so I didn't really know how to answer it. And his face just fell and he said to me, "You mean my son is going to die?" I didn't know he was a father there. His son had just been discharged. And the only thing the doctor said to him was, take him to this place. So he thought he was being referred to a children's hospital. And to his terrible luck and to mine, we encountered each other. And that's how he found out where he's going. His trust in the healthcare system that day must have plummeted. Okay, so someone's diagnosis, do they know what they have? And please remember, knowing what you have is very different from understanding what you have. I have idiopathic interstitial lung disease. I know the word. Do I know what it means? And very quickly, you all know this, anyone who has a disease and any caregiver will quickly become masters of that language. Metastases, myelopathy, they know all the words, they've done all the research, Dr. Google has helped them, whatever. You ask them what that means, they can't express it because no one has broken it down. How does that process in your body? What does that mean in terms of your energy levels? What does that mean in terms of your ability to be independent? They don't know. So don't just take it at face value that just because they know the name of the disease, they know what the disease means. Please go a step further and say, tell me what that means to you. That will tell you how much insight they have, not them jhadoing the name of the disease. Okay. So that's that's something that I'll ask you to bear in mind. And if they'd prognosis, of course, we'll come to that. Prognosis, if people don't know, there's collusion issues, there's all kinds of issues. We will talk about that in the communication section. And of course, if they don't know what palliative care is, or worse, if they have the wrong idea about palliative care, which is, oh my God, palliative care is just going to hasten death. Oh my God, they're going to give me medicines that are going to cause addiction. You have to correct it immediately. Okay. A lot of people think, oh, palliative care means giving up. It's not giving up. Right? So this is where you clarify and you check with them what they know about palliative care so you can actually encourage them, because what will happen is a lot of people then just fall off and they go to another doctor. That's when the doctor shopping starts. Okay, so this is very important. Now, again, show of hands, please. How many of you here know what a genogram is? I'm sorry, for some of you, you might be very familiar. So this is repetitive. Genogram, anybody? Okay, Aparna knows. Neeta knows. Okay, I'm going to go ahead with the assumption. Okay, here come other names, Shweta, Ashi. All right, so great. So lots of people know, but I see that the majority of the group here does not know. Okay, so I'm going to just take you through it. For those of you who have worked with genograms, you might find slight variations in mind. Genograms can be adapted to different situations. Yes, I just see some aha moment happening there. But genograms can be adapted. Okay, so if you see a variation in what I'm showing you, that's fine. This is just how we use it. So a genogram is basically a graphic a representation of the family tree. It was invented by someone called Murray Bowen, and it tells us a few things. Okay. Firstly, you have to do it for 3 generations. You can't just do the nuclear family and say this is the genogram. Your genogram has to have 3 generations, whether they're living together or not, whether they're dead or not. And what this will tell us is the structure, the dynamics, the strengths, and the resources. And the type of information that you need to put into it is name. I'm going to show you what a genogram looks like, so don't worry. Name, age. If you want, you can put in educational, occupational, status, profile, and emotional relationships. Personally, I insist on emotional relationship being shown. Now, let's look at what some of the symbols are. Okay, this is very standard stuff. You can Google it, you'll find it. Male is usually depicted by a square, female by a circle. A married couple, there'll be a line between them. If they're separated, there's a line crossing that. If they're divorced, there's a double line. There are, again, depending on the kind of work you do, not all of you are in palliative care. Some of you might be in mental health. Some of you might be in other social services. You might need to know whether the child is adopted, whether it's foster child, whether the woman is pregnant, whether she's had a stillbirth in the past. So in maternal and child health, you might need to know about this to determine her history. Miscarriages, so twins. This is on maternal and child health. You might need all of these. But also we sometimes use it in our settings depending on what is necessary at the time. Emotional, don't be overwhelmed by the slide, please. I will share it with you. But suppose, okay, so saying that this is a man and a woman, a dotted line means indifferent, apathetic. Strong green line means harmony. Okay, now please understand something. You can customize it to your team. It doesn't have to always, there's no universal. I mean, these are the most commonly depicted ways of showing it, like violence and hostility. Hostile is usually shown like this. Violence is shown, these are sharper spikes together. Abuse is shown in, and so you use different colors and stuff. Now, at first, it might seem very daunting, but as you become adept at it, the beautiful thing about a genogram is you can have one genogram and you can keep working on it. And if all the people in your team know how to read the genogram the same way, you don't have to write notes and notes and paragraphs of notes. You don't have to write a paragraph on the fact that these two are divorced, or this is there's a new person in this person's life, or they have 3 children, what their names are. It's all there in one place, and anyone looking at it can add to it, can read it. So it's like reading a map of the family. Okay, and I find it to be extremely time saving, and it's a, especially when you are on the field and when you don't have too much time with a person, this is a quick way to make this diagram. Because if you're sitting and writing notes while the person is talking to you, first of all, you're not making eye contact, you're not responding to them. Here, at least you have a quick way of jotting things down. Okay, so now let's look at Ramu's family. Who wants to read out this genogram to me? Just to tell you, the dark gray, the people depicted by dark gray are people who've passed away. Okay. So, anyone wants to volunteer to read Ramu's genogram? Don't worry if this is your first time. Let's try it. I just want to be sure that I'm conveying this to you in a proper way. Somebody who hasn't worked with genograms before? The cross just shows that Ramu is the patient. Okay.
I can try.
Yes, please. Go for it.
Okay, so Ramu, who is 45 years, is the case we are discussing about. He was married to Sindhu, who is no more, and he has a child from Sindhu, who is 16 years, Saran, and the child is in 7th standard, who is a boy. Boy, it's a square, so it's a boy. And Ramu is a child of parents 75-year-old Mohan and Leela, 68-year-old. Who are alive. That's what it says. Ramu is now married to Sindhu, who's 42 years. Now again, the name is Sindhu, so I'm a little bit confused.
Oh, sorry. Sorry, that was my mistake. Okay,
Yeah,
let's
okay.
call her Manjula. Okay.
Okay, Manjula. Manjula, and she's 42-year-old, and they have 2 children, 2 boys, Amal and Vimal, who are both look like twins. Yeah, they're twins because the stem is coming from one point. And Sindhu is a child of Kumaran and Malini, who are no more.
Great,
And
fantastic.
it doesn't talk about the relationship between the people. It doesn't add any emotional component here. Yeah, that's it.
Fantastic. Fantastic. But it tells you structure.
It tells
Yeah.
a structure. Yes, 3-generation structure. Yes.
Now, fine. So we have this. I'm going to take it a step further now. Oops. Oh, sorry. Manjula is a sister. Okay, let's call the alive Sindhu something else. We'll call her Miriam.
No, the left Sindhu and the right Sindhu is fine.
Yeah. Okay. No. She's actually, let's call her something else. Let's call her Priya. Okay. His wife. Now, okay, I'll just tell you something. Blue lines are strong connections. Okay. Red jagged lines are hostile. Double lines is best friends. And green single lines are harmonious. No problems between them. So, and also the circle means that this is the unit that is living together. All right, so now I know who's living with whom. Does anyone want to attempt this?
Shall I? I don't know.
Go for it. Go
I'm
for
a
it.
bit confused, but I thought somebody will take it. Okay.
No, go for it.
So, so Ramu is staying right now with is not staying with his wife Manjula.
His wife.
Okay. His wife Manjula. No? Sindhu is Manjula, right? No?
Yeah, Uma, can you?
Yeah.
Yeah.
So I think Manjula is so Sindhu we renamed as Priya, who's the wife now, and
Okay,
Manjula
Priya.
is
Okay.
the sister. Yeah, I think.
Yeah,
Go ahead, go ahead.
this is Priya. Okay.
Okay. Okay, then shall I? Okay. So Ramu is staying, living with Sindhu and his two twin children, along with a 16-year-old child who is a boy, who is a child of a close friend of Ramu, whose name is not written. He's 43-year-old, and they are close friends.
No, no, no,
45-year-old
no, no,
Ramu
no,
and
no, no.
43-year-old man. They are
Uma,
close
yeah,
friends.
sorry,
Yeah,
Uma. No, no,
yeah.
no. I'll just take you back. Sorry, this is the
Okay.
confusion. So this this is Ramu's brother. They come from the same.
Oh, okay, okay, okay,
Okay,
okay, okay, okay. I missed that line. Yeah.
no problem.
Ramu's um, brother's son.
Yeah,
But why are the two lines there? The line is coming from both Ramu as well as the other person. I can't
the
make
other
out.
person is his wife. He's married to her. This is coming from on top.
No, Saran is whose son now? They are friends. Is
No,
it?
no. Sharan is with with his previous wife.
Oh, yes, yes. I was missing out the black dot. Yeah, correct. And they are all close friends. Three people are very close friends. His first wife's son, Sharan,
Hmm.
and the brother, who is 43-year-old, and Ramu. They are very close friends. And but the brother doesn't stay with them. Okay, the brother, yeah, his first son and the current wife's son, all the three siblings are staying together with Sindhu, with Priya and Ramu.
Yeah,
Ramu also has a not so good relation with the Manjula, who is the other child of the sibling of Sindhu, Sindhu's sister. Sorry,
that's right.
Priya's sister. Sorry, Priya's sister
I just realized there's another
doesn't have
Priya.
a good relationship, and Sindhu also does not take care of the stepson, or maybe there's a violent behavior relation between Sindhu or Priya, sorry, Priya with her stepson.
Yeah,
That's what I can make out. And there are two lines between Priya and Sharan. I
they're
forgot what are
cousins.
two lines. Consanguineous marriage.
No, 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 no.
Oh,
They are. Sorry, I'll take you back to the previous thing. That is best friendship. They're very, very good
okay,
friends.
okay, okay, okay.
These are they're basically cousins of the same age, and they're very, very
Hmm,
close. Okay, so
okay.
thank you, Uma, for a first time. That was fantastic, and notwithstanding my own the confusion I added by naming both the wives the same thing. But okay, so here you get this. Yeah. Now, when you look at this picture and this family, what do you know about Ramu that you did not know earlier, and what do you think his concerns might be? He is living with his present wife and the children he has with her, and his son from his previous marriage. The relationship between the stepmother and the stepson is not great. In fact, there's some hostility there. Uh, her close person is her sister, and the sister also doesn't like Ramu much. Sindhu looks like she is very close to her two sons, also may be protective of them. Ramu probably seeks support and comfort from his brother, and advice and guidance from his brother. And the brother is also quite close to the son from the first marriage. Okay, so this unit seems to be quite close to one another. The son from the first marriage and all of these folks. These live together, but there seems to be some strain, although the young boys themselves are okay with each other. Now, with this information, what are you going to do with this information when you're talking to Ramu? Or when you're trying to plan things for Ramu? What might his concerns be? What does this picture tell you? In a crisis, who do you think Ramu talks to?
His brother.
Okay. So do you want to involve his brother in the plans and goals of care?
Yes, probably, yes.
What might his concerns be for his son for Sharan?
That he's not in good terms with Sindhu. And I can't make out what is the relation between Sindhu and Ramu.
Nothing remarkable.
Okay.
It's not
Because
too.
that would
It's not.
also influence the way Sharan would respond to Ramu's needs. That's all I
Anyone
can.
anyone else?
Ramu may be worried about Saran's future.
Yeah, he's already lost one parent, biological parent.
Yeah. So he may get his brother's family to look after his education and future goals.
So what we're seeing there is a potential source of support. Correct?
Yeah.
So that's a conversation we might want to encourage between the brothers,
And
right?
at the same time, I think even though he doesn't get along well with his wife's family, which is that part of his family may be taken care of. At least they have some support.
Yeah. Also, we have to see that Ramu has elderly parents or aging parents.
Yes.
So that's going to be something that is also problem. We might
But
need
he
to.
still has a brother and his wife who can take care of the
Yeah. So
parents.
this is just the first draft of Ramu's genogram, okay? But already, see, we've learned so much. We know now where some of the problems are. We might need to resolve this relationship between who I call Sindhu, but the current wife and his son from his previous wife, right? This relationship needs to heal. Probably that's a concern for Ramu, right? So we're looking at what we're seeing here is potential areas to work on, because what do people need when they're seriously unwell? They need to heal relationships. They need to have better coping mechanisms. We're also looking at probably financial support and things like that. Okay, so I'm going to move forward from here. Are we clear about the genogram and how it works? So it will take some time, guys. It will take you a while to actually really look at these. You might need to look at this table over and over again to keep marking it out. Then you have a conversation with someone in the family and you realize, oh, actually there is some little bit of estrangement over here. Or you might find that, this person is very focused. There's an arrow. All this person's needs, all this person's attention is just focused on this one other person. So those kind of things, it'll come to you over a period of time. And then reading a genogram also becomes easier and easier. Okay. Now, it's very important to know the current status of important relationships, because that'll tell you who is supportive, who is estranged, who's isolated, and whose relationship is altered by illness. Please remember that if a family had dysfunctional patterns before a crisis hits, chances are those dysfunctional patterns will get worse. So within families, we have allies. Within families, we have people that we're closer to, not so close to, all of that. So sometimes relationships fall apart after an illness because of the pressure the family is under. Sometimes the relationship gets stronger. Okay, so we have to know the relationship status. And the second thing I want to introduce you to is something called an eco map. It was designed by a lady called Anne Hartman. And like the genogram is a pictorial representation of the family structure and dynamics, this is a pictorial representation of a family with its environment, social environment, and the family's relationship with larger society. And what it is doing for you is that it's giving you a snapshot view of important interactions of the family with systems and groups of people around them. So what does this mean? Family, who do they interact with the most? The school, the child's school, health services, extended family, friends, neighbors, workplace where they were employed or are employed, local services like your panchayat, your infrastructure folks, your tax department, all of those things, and religious institutions, if any. Now, I've just put this down in a sort of quick look way. Here also there are dynamics. So the family and the health service so far have had a hostile relationship. Okay, they've not been good to one another in that sense. I mean, certainly the health service has not been kind to him. With the extended family, it's weak. Now, arrows show you the direction of the energy. Okay. Now, in this case, I've put it like this, simply taking into consideration the wife side of the family. It's a weak relationship, but this can be changed. Neighbors, a very strong relationship with the neighbors, a very strong relationship with friends. The school has so far been very understanding of the family's condition, and the family seeks a lot of refuge and comfort in their religious institution. So they're a deeply religious family. Okay, so I'm just giving you a sort of example of how you can show it. Now, I did not put together Ramu's specific eco map, but I will show you another eco map just to give you an example. While you can show the family unit with all these institutions, you can take it a step further and you can show what every member in the family, in the unit of family that's living together, not all three generations, just the family that's inside the circle, what is their individual relationships with each of these. Now, to show you an example of that, like I said, this is not Ramu's family, but this is literally from one of our case note, like on the field notes that someone has made. Now, here is the patient. Okay, she is the woman, the husband, and they have two children, a boy and a girl. Now we see what the relationship is with each of these people. And you don't have to show all four with all this stuff. You know, there are people with whom, like, for example, the whole family is very deeply religious. So they have a very strong connection with their church. The neighbors generally have hostility towards this family. The younger daughter has a very strong bond with a youth organization. Okay, the school has a good sort of rapport with the girl. Both the children have a strong rapport with their friends. This guy is an older boy, and to him, his college is his escape, and his college is where he goes to feel, better about life. The public health center has a weak relationship with the mother, who is the patient. And the father looks to his colleagues for support. And it's a two-way street. He's good friends with his colleagues. He probably goes out in the evening, gets a drink with them, and, de-stresses from the day. And the self-help group really sort of focuses on the well-being of the mother. Clear? Does this make sense? So by creating this eco map, what it tells me now is who I can lean into for each of these family members. I need to encourage this young girl to continue with her youth organization and not lose touch with them, because it's a source of great support. Okay, there's a volunteer in the community who comes to help the family out. I need to speak to the volunteer and find out more about how we can help the family, because very often it's this person who has a slightly zoomed out view will tell me, yeah, you need to help out. I probably understood about the neighbors from this volunteer. I need to improve the public health center's relationship with this woman. What is the problem? Why is she not being able to develop a stronger relationship there? And their friends. But what kind of friends? Are the friends a good influence? because sometimes what happens is in illness, children will act out. So I need to then explore their friendship a little bit more. Okay, so this is what an eco map tells me. It tells me where are the resources and the supports within the larger setting that within which the family exists. If someone in the family has a stigmatizing illness, disease, like HIV or tuberculosis or cervical cancer, then that makes the eco map even more important. Are they isolated? Do I need to do an awareness exercise in that community to say, hey, listen, it's not contagious? Or, maybe neighbors are not letting their children play with the family's kids. Why? Because they think that something might there's some problem associated with that. Do I need to intervene there? The school is not, accommodating. Is it because nobody has explained to the school how badly off the family is? So those are interventions that our social workers can make, that our nurses can make, that our community health volunteers can make. So the eco map is a beautiful way to find out outside of the family, where can they get support? Because let me tell you also, I mean, I'm sure all of you know, when a family is going through a health crisis, sometimes each member in the family is exhausted. You can't lean on other people in your family because I don't want to talk to my mother because she's exhausted. I don't want to talk to my brother because he's irritable. I want to go to that youth organization. I want to go to my church. I want to go to work and hang out with my colleagues. And it's important for us to take care of individual social needs of the family members. So that is how we strengthen the family's coping system as well. Okay, so eco maps are useful. Yes, that's a leading question, but eco maps are useful. Okay,
Smriti, can I ask a question?
no, please go ahead.
Yeah. So the last eco map that you showed us, made by it's an actual case from an actual case study, right? How many visits to the patient's family or the house did it take to make something like that?
Very good question. Sometimes it takes a lot of time, one. It's very rare that you'll get all this information at one shot. It will take at least 2 to 3 home visits. Or even once you've done a home visit, it might even, the next thing can happen in the outpatient unit also. It doesn't matter. But it will take 2 to 3 sessions because you're building that rapport. Also, if there is a hostile relationship with the neighborhood, that's not easy to elicit.
Right.
Depends on the community, depends on the kind of neighborhood. If they themselves have internalized the stigma, it's going to be hard for them to talk about it. But in that case, I have identified a volunteer in the community who goes in. I'll go to them. Not all the information has to come from the main family. You can talk to extended family members also. I am very mindful of the fact that we have a case presentation. So I want to give that the space as well. So I'm just going to go back to this and try and wrap up my part, sorry. So anyway, so eco maps and genograms, try and have both for your families that you work with, because it really gives you deep insight into where is people's roles and positions and responsibilities. Because what you see sometimes is not what you're not really seeing the truth. Okay. Now, socioeconomic status, I need to know whether they have adequate food, water, clothing, and shelter. What is the point of me giving free medication if the person doesn't have food to eat? Is there a way that I can put them in touch with a social services group that will provide them with that food, or get them under some scheme? What are their living conditions? Acha, I've given all this medication and all of that. It's Kerala. The monsoon has come. The roof is leaking. And the position of the bed can only be there because the room is so small. I can't move the bed position. If I move the bed position, the person goes more towards the chula where the smoke is coming from. So I need to know their living conditions. That will also help me understand if they need some respiratory help, things like that. What is their source of income, especially when the breadwinner has stopped working? Who is the breadwinner? Who controls the finances? And here's a tip which seems obvious. The person who controls the finances is the person who controls the decisions across the board. Sometimes it's the uncle who's sending money from Dubai. who's not involved in the day-to-day care. But because it's his money that is going towards his sister's treatment, the niece and nephew have to toe that line. The doctor will say, hey, this is what I prescribe, but it's going to cost so much, but this will really benefit your mother. I then have to go to my uncle and explain, can we please do this? The person who controls the finances controls the decisions. So find out who that person is, okay? Are there debts in the family? What is the status of education of the children? Social support through government schemes, local financiers, financial support. Now, very often there are schemes available in so different states in India and even sometimes different districts have different schemes available. Like for example, in Kerala, you have a caregiver pension scheme. So find out what those schemes are in your state and make sure that the family is actually making use of it. That could be an additional source of income for them. Do they have access to transport? Such a silly question. But I need to know, because I need to know how do they get to the nearest healthcare center? What will happen in an emergency? So I need to know, we need to make a contingency plan, an emergency plan to say, in case of an emergency, this is the plan that has to be activated. It means involving your neighbor in the next apartment. It means involving this volunteer who will drive you. So have a conversation with all those people and say, okay, it is likely that in the next couple of months, this is the kind of emergency hospital visit that may be needed. Can you all please be available to the family? Yes. So the family also feels a little bit better about it. I know things can change and that might change, but at least you have a plan of action in place. Okay. So access to transport, these are things that we need to understand. Psychological status, what is the kind of distress they're experiencing? What are the emotional support needs? I will talk about this more in our mental health module, so you don't have to worry that we're skimming through it too fast right now. What are the risk factors? Risk factors could be stigma. It could be financial toxicity. Risk factors could be intense pain, intense pain. It could be and not just pain. I once had a patient who couldn't stop vomiting. And we couldn't ascertain the reason for her vomiting because we couldn't do a blood test. So vomiting is one of those symptoms that could have several causes. It could be an inner ear imbalance. It could be nausea. It could be something in the GI tract. It could be an emotional memory. It could be so many things. It could be very well be a reaction to a chemical. Now, we couldn't even draw blood from her because she was so terrified of needles. But that distressing sort of symptom was a risk factor in her contemplating suicide. Okay, so what are the risk factors? Now, what are the other risk factors to the family? They're this close to being financially obliterated. Okay, so what can we do quickly to support them so they don't become homeless, so that they don't stop having access to food, water, shelter? And suicide risk, is an assessment required? If there are risk factors, if there is someone who's deeply distressed, do we need to do a suicide risk assessment? Okay. Spiritual assessment, where are they with their sense of feeling? Are they still connected to people around them? Where do they find strength and comfort, hopes and concerns? Again, I will share this resource with you. Ashley, please make a note of it. There is something, it's beautiful. It's the Oxford Spiritual Assessment tool. I encourage you to use it more as a guiding document to a conversation rather than a checklist. So I'm happy to share that, and I'm happy to take questions about it as well later. And of course, psychosexual assessment. How has the illness impacted sexual intimacy? Has it changed the quality of the relationship? And these are, again, very tricky areas to go into, but especially, like, for example, in cases where there's been a spinal cord trauma and one partner has been paralyzed, beyond a certain point, they're no longer able to perform sexually. They're a young couple. How does it impact the caregiver, the other partner? Sometimes we find that it leads to conflict where the one partner who has been affected is distrusting of his or her partner. And this happens a lot when the role is that the caregiver is a woman and the male is wheelchair bound. And I've seen more than enough cases where this becomes a serious sticking point in conflict. Even if she's just going out to buy some vegetables and she takes 15 minutes longer, the husband will say, "What took you so long?" So it's very important to work on that trust and work on those things. So again, I'm not going to go deeper into it right now. We will talk about it in more detail later. And finally, once we have all of these things, slowly as we go along, we then have various interventions. So number one could be that they don't have the information they need, right? So how do we figure out what are those information gaps? They may not know their diagnosis. They may not know the prognosis. They may not know what palliative care is. They may not know what subsidies are available to them. That's the information we need to talk about. Liaison with local authorities. Talk to the panchayat about getting a water supply. We've done this on several occasions where we facilitated a bore well or a water pipe connection, because otherwise people were walking 2 kilometers to get a bucket of water. Regular follow-ups, empowering the family. Okay, you're a caregiver, but here's how you can help with hygiene issues. Here's how you can manage certain things at home. This is where you need to bring the person into a hospital, because what happens is very often in a moment of panic, the family will rush to the hospital. And it could very well have been something that could have been taken care of at home. So we're empowering families to take care of those things at home. Rehabilitation wherever necessary. Facilitation, when I say facilitation, I mean like what I said about the transport. How do we get someone from point A to point B? How do we get them access to medicines on a regular basis, to groceries? What if it's an elderly person who's bedbound and at home? How do we get basic food rations over? Okay, supportive counseling, of course, from the interdisciplinary team. So these are various interventions. I have purposely not put down things like cognitive behavior therapy and stuff like that, because for that you need a very specific skill set, which generally we're looking at a more broader thing. So of course those also have a role to play, but I'm not getting into those because that will come under supportive counseling or even information and stuff like that. Okay, so to summarize, please remember that assessment is a working hypothesis. It's an ongoing process. It is a participatory process. I cannot assess somebody without the active participation. Okay, and information can be derived from different sources. And what it really does is helps you identify the impact, the overall impact of the illness, and what does the patient have in terms of resources and strengths, and to counter it, what are the power dynamics within the family. And assessments have to be documented, revised, and updated like you would do with any medical document. You have to have accurate information. So if you find that information is changing, it has to be updated in the genogram, in the EcoMap, and in your case notes. So I'm going to, I think, leave you with this. Now that we've gone through all of this stuff, how do you think you can help Ramu? Right? So this is something that we will just leave you to think about. If you want to drop me, this is not an assignment, but if you want to leave me a little note, you can send it across to the coordinators and they'll send it across to me. Okay, Shala, I have eaten into your time. So I'm going to stop, and I'm very sorry. I'm going to request the grace of the group again, in case we go a little over time, to please stick around, because I know a lot has been covered in Shala's presentation, and we want to give her that time as well. Shaurya, I will respond to your question after Shala's presentation. Yes.
So, ma'am, can we have the case presentation now?
Shala, you want to
All
take
right.
Yeah, all right, there you go.
Okay, so the patient is a female, age 41, and she was diagnosed with pelvic mass sarcoma on the right side, and her occupation was a foreign accounts payable manager. The patient had been diagnosed with pelvic mass sarcoma on the right side, and she experienced various symptoms, including uncontrolled pain, nausea, vomiting, swelling in the abdomen, vaginal swelling, difficulty swallowing, and loss of appetite. In addition to cancer, she was diagnosed with a urinary tract infection, throat infection, and stomach infection. The patient had received treatments with antibiotics and steroids to address the infections. She had also undergone radiation therapy and chemotherapy. I just saw a question in the chat box asking which country is this case study from, and I am from Trinidad and Tobago. Insights, the diagnosis, the patient had insights about her diagnosis and she fully comprehended it and demonstrated acceptance. The family also had significant insights about the diagnosis and were accepting as well. The prognosis, the patient had experienced a range of emotions that can be described as a pendulum-like experience. So she fluctuated between acceptance and resistance to her diagnosis with hope for a cure or miraculous recovery. She was a devout Christian, while she grappled with the harsh reality of her situation and the uncertainty of her family's future. The family, however, particularly the husband, he demonstrated resistance to accepting the prognosis, and which may have added additional pressure on the patient. And the pressure could have intensified the patient's own efforts to fight against the illness despite the challenges she faced. And insights on palliative care. The patient had the knowledge of palliative care and understood its significance in her diagnosis and where she was at presently. She felt that her pain was only controlled when interventions were made by the palliative team. Her family, on the other hand, they believed that palliative care was necessary at this point as well and welcomed us to assist. So her family overview, she lived with her husband, 11-year-old daughter, godmother, and autistic brother. Her 11-year-old daughter, who understood that her mother was gravely ill, but was encouraged to focus on her exams. Her upbringing was marked by early parental loss, leaving her orphaned and under the care of her godmother. She has faced various forms of abuse in childhood, and despite these hardships, she felt indebted to her godmother for the role she played in her upbringing and her contribution to the quality of life she had achieved. She was married for the past 10 years, and the marital relationship seemed strained. The strain in the relationship remains somewhat inexplicable. We would have heard varying stories while treating her, but we cannot exactly say what would have strained the relationship. However, her husband was a naturopathic consultant and he holds strong anti-Western medicine beliefs, creating tension within the relationship. So although he wanted the palliative care to intervene and for us to offer pain control, he also felt that, the medication was making her exceedingly groggy and stuff like that. Her autistic brother, due to his intellectual limitations, struggled to grasp the gravity of the situation. He only recognized that his sister had now spent the majority of her bedbound days in their living room because they had converted their living room into a hospital setting. She had a very close friend that was a female who was also strangely appointed as her daughter's guardian upon her passing. This overview paints a picture of complex family dynamic where past traumas, differing beliefs, and caregiving responsibilities intersect, shaping the individual's experience and relationships within the household. And this is our eco map. She had a positive relationship with the autistic brother because, like I mentioned before, she felt as though they were orphaned and she was responsible for the brother. Her father, which she would have mentioned, it seemed, but we are not sure if it was her biological father or if it was just the godmother's husband, but they seem to have a sort of tenuous relationship. She had a strong relationship with her godmother and daughter, and she also had a positive relationship with the daughter's godmother, who would have been appointed the guardian. She also had a very strong relationship with our team as well. And the relationship with the husband was very, very stressful, as I mentioned prior.
Shala, I'm just going to stop for a second because I know this
Sure.
might be confusing to a few people because the EcoMap and the genogram that I showed was a little bit, so here it seems like a combination of a genogram and a EcoMap, which is also fine. It's not right or wrong. But just to sort of clarify in case people have confusion about what I showed you and what's happening here, because here what Shala has also done obviously is a EcoMap of the patient being in the center with all the others, including the palliative healthcare team and so on. So this is actually a good example to show you that in your setting, you can adapt it. So whatever works best in your setting. So sorry, Shala, I just needed to clarify that while we're here and then we can move on. Yeah, please go ahead.
No problem. So, all right. So her socioeconomic overview, she belonged to the middle income bracket in my country, and she served as the primary provider for her family, bearing the weight of all the financial responsibilities. She held a managerial position, excelling in her career with a track record of educational achievements, including a master's degree. Her husband's naturopathic business struggled to generate sufficient income, and it did not alleviate any of the financial burden in the home. So there was immense financial suffering by depleted savings and limited insurance coverage. Difficulties managing her health issues given the economic hardships facing her family. So even though she had medical insurance in my country as well, they only cover a certain amount. And if you don't write the insurance form a particular way, you would not be reimbursed as well. Psychological overview. The loss of her mother at a young age had a profound impact on her. She struggled with feelings of confusion, questioning why her mother had to die when she was still so young. The pattern of mothers dying young in her family, including her grandmother's death when her mother was also young, led her to believe that such occurrence was a sign of doom or inevitability for the woman in her family. These experiences likely contributed to her sense of vulnerability and uncertainty about her own future and the well-being of her daughter. She was also a victim of sexual abuse and physical abuse due to the lack of supervision and parental guidance and protection. So she was very, very afraid that these same things would happen to her daughter. So she endeavored to remain resilient for her daughter, who was at the time preparing for national exams. So legacy planning allowed her to create meaningful connections and memories that would endure beyond her lifetime. I was even privileged to do the legacy work with her, where we would have sat for hours and written letters, various letters for her daughter, from for her 12th birthday, 16th birthday, when she gets married, when she has a baby. We would have cut a piece of her hair and placed it in a locket. Where the daughter would be able to wear that locket around her neck, because one of the things she wanted to do was travel the world, and she never got to leave our country. So she endeavored to, put things in place to allow her daughter to leave the country when she gets older, and that she could take that locket with her to carry with her all over the world. So these acts of love and foresight really demonstrated her deep commitment to her daughter's happiness and security, even in her absence. Her husband, a naturopathic consultant, like I mentioned before, he held beliefs conflicting with conventional medical treatments such as chemotherapy and radiation, which she underwent. I will just put in here that when she was diagnosed, before the palliative team came in, her husband did not want her to go to do chemotherapy and radiation. So that put a bigger strain on their marriage as well. And it had a period in time where, in the beginning of your diagnosis, with all this uncertainty, her husband really was not speaking to her. So you are going through this process, and this person that you vowed for better or for worse with is not even speaking to you. So that really took a toll on her as well. And she struggled with the notion that accepting conventional treatment worsened her diagnosis. She grappled with the feelings of guilt and uncertainty, pondering whether a different choice could have altered her fate. So her husband also introduced like natural medication to her during end stage or end of life care. And I don't know if it was like a mind over matter thing where she felt that she was better with taking those things. So she questioned if she had listened to him in the beginning, maybe she would have had some preservation of life. And she fluctuated on that pendulum all the time, oscillating between acceptance of her prognosis and considering alternative natural remedies advocated by her husband. As mentioned, she really clung to hope and expressed disbelief at the gravity of her situation, finding it difficult to accept her unfulfilled life aspirations. So, like I mentioned, she was young, she had a really good job, she moved up the corporate ladder, she had a pretty okay-ish family dynamic, and she really defied the odds of her childhood. So it's like, now I'm hit with this. Why am I hit with this? I can't believe this is happening to me. I've achieved so much, but then there's so much more that I want to achieve. I cannot accept this. And if I accept this, I think that I'm accepting debt and basically just giving up. So that is where she was. And there was a deep sense of indebtedness to her godmother, as she would have felt she saved her when she was younger, and her mother died. And now she's saving her again during her diagnosis. So when her mother died and she was so young, there was nobody there. She had no support. And now she's going through this terrible diagnosis. The godmother is there again to swoop in and to save her. Like I mentioned, the relationship with the father is questionable. Our team was not able to establish the true dynamic of the relationship or actually who the father was. There was an older gentleman in the home, but he always was far off when the team visited. So we could have never ever determined. And her total pain, physical, she had an ECOG of 4, meaning that she was completely disabled, bedbound, not able to perform any activities of daily living, and was fully dependent on a caregiver. She had uncontrolled pain, severe nausea and vomiting. Psychologically, she was not ready to die. She felt as if she accepted that was her end. It meant that she gave up. She felt again that her mother had passed away when she was young, leaving her to navigate life without parental guidance. That was happening again, but now to her daughter. So she questioned, is this a generational curse? How can I break this? She also expressed that her pain relief was only experienced with IV medications, which was carefully monitored by our team to avoid potential issues with dependence, as well as her socioeconomic. She was married and was the primary earner for the family, main caregiver for their autistic young brother. She faced a strained relationship with her husband, experienced severe financial hardship. The 11-year-old daughter was preparing to write national exams, and national exams in Trinidad and Tobago is really the exams that will possibly determine the course of your life. It will determine which secondary school that you go to. And here, very much, depends on the school that you pass for will determine how bright you are. So you have that pressure on you at a young age, and then to be dealing with your mother's cancer diagnosis was probably really overwhelming for her, and the mother thought about that a lot. And she was orphaned shortly after birth and raised by a supportive godmother. Spiritually, the patient identified as a Christian, but there was some confusion and questioning about why God would allow this suffering to happen to her family once again. And despite the confusion and questioning, she continued to seek God for a miracle, holding on to hope for a complete turnaround in her situation. So the discussion points, how can you establish a solid foundation for good practice, considering the intricate family dynamics and the significant influence of the husband's naturopathic medical beliefs? How do you address strained marital relationship when one spouse's advocacy may not align with the patient's best interest? And how do you navigate these difficult conversations while maintaining trust, especially after being introduced as a partner on the patient's healthcare journey when expectations may not be met, leading to disappointment? And if after establishing effective communication, how do you navigate complex ethical issues surrounding end-of-life care, which can be deemed as futile? And how do you manage expectations as the patient and family experience the emotional roller coaster of a life-changing diagnosis after goals of care are established? And this is what our team did. So we cultivated trust and rapport with both the patient and relatives. We listened actively to their concerns and validated their perspectives. We recognize the significance of the spouse's non-conventional medical beliefs and the role they played in the family's decision-making process. We acknowledged their beliefs while simultaneously providing evidence-based information about the patient's condition and treatment options involving their suggested interventions. So the husband, in the end, while she was actively dying, he wanted us to give her vitamin C IV. And at this point in time, it was futile care because it was not doing anything. And of course, you have to pay for this. So we don't want to be charging you for a service that is really not beneficial to the patient. And we also encouraged open communication, allowing each person to express their thoughts, concerns, and preferences regarding the patient's care. And we created a safe and non-judgmental space for conversation where everyone felt heard and respected. We also took time to educate the family of the patient's diagnosis, prognosis, and treatment options, and ensure that the information is always communicated clearly, addressing any misconceptions about conventional medical treatments by offering evidence-based insight to support informed decision-making. So it came to the end where she was in a lot of pain, and they found that, she was very loopy when she would have taken the medication. So they felt as though she even said when she still had capacity that she'd rather be in pain, she'd rather feel the anguish of the pain than to not be out of it. But then she was in so much pain, she was vomiting, it was really terrible. So we showed them that, hey, you know what, we can give you the pain medication, we can also have the naloxone to reverse any droopiness right by your side to ensure that she has pain relief and she is comfortable. So even the quality of that was very, very important to us because we did not want her to die in pain. We also didn't want to put the family through the trauma of her dying in pain as well. We recognize the uniqueness of the patient and the family. As I mentioned, the husband is totally anti-Western medicine. He believes that, there is a plant for everything, which is fine. We supported him as well. So we tailored care plans to align with their cultural, spiritual, and personal values. And our approach to this case was just one of compassion and empathy. And we really, really respected the family's belief. Even if we didn't agree, we would always support and say we understand. And we fostered open communication to establish a solid foundation for good practice that promotes the well-being of the patients and their family. And in closing, I would say that we used a multidisciplinary team approach. We were able to establish successful goals of care. We got her to be DNR, DNI, DNH, and to ensure that her treatment plan was tailored specifically to minimize total pain. Our doctors division, in tandem with our nursing division, visited daily to this patient's home to ensure symptom management, to ensure that her pain was controlled. Our lead consultant had in-depth conversation to determine her goals of care, her goals which would be achieved, which contributed significantly to decreasing her psychological pain. That's how we came up with the legacy planning and all of that. And she was also encouraged to continuously trust in God and put her hope in Him regardless of the outcome. And her socioeconomically, our team identified that there was grave financial suffering and was able to place her on something called the Live Health Charitable Foundation for 100% funding. That is a foundation in my country which allows persons to access palliative and hospice care. and the funding helped by substantially alleviating the financial burden to her. So in her last days, the money that she had remaining, she was comfortable knowing that she no longer had to pay for palliative care. She could have left that daughter back for back for her daughter, as well as to be buried. And she was now focused on, okay, this team is taking care of me in every aspect, and I just have to accept it and accept that this is it, but I can still hold on to faith. And this is how we'll move forward. And this is how I think we were able to lay the foundation for good practice by just really going in and getting to know the patient. We knew her diagnosis. She was in the private hospital, so we got that whole patient discharge. We knew what was wrong with her, but we did not know her. And in order to really lay that foundation, you have to know the patient. You have to know the total pain. You have to know all the things that they are suffering with in order to really create a plan and achieve successful goals of care that would help the patient as well as support their family through their healthcare journey.
Thank you very much, Shala. Thanks a lot. And Sangeet, can you stop sharing screen, please? Yeah. So I know we're slightly over time, but I just want to, first of all, congratulate Shala. What an in-depth presentation, not just in terms of eliciting the concerns of the patient and the family, but there were some very tricky issues there. There were some very tricky issues with the disagreement with the husband on plans of care, goals of care, methods of care. And I just really want to say that I'm very profoundly moved by the way the team was able to hold space for everybody. Sometimes we tend to, if somebody's worldview doesn't agree with us, we cut them out of the equation and we say, okay, it doesn't work, so we'll just talk only to the patient. But I just want to say that that was fantastic how the team holistically actually carried everybody with them. I'm also thinking of the curse and how heavily that must have weighed on the mother, and to have this happen in the third generation, and how that crafts the narrative of a family. And this becomes the family story, it becomes the family myth, and how that can become a very impeding sort of energy in the family. So very quickly, I just want, with your permission, just go on for 5 more minutes. I want to invite reflections and questions from everybody. If you can put on your cameras, please do so. Reflections for Shala and any questions for me. Does anyone have any questions?
Smriti, I have a question.
Please.
Do you, when you form your palliative care team, and probably this includes the last session on IDT as well, do you all sign NDAs with the patient, or is that an assume, because you all are not all of you are doctors, so there's no Hippocratic oath? I'm trying to understand on what basis do they start trusting you and share intimate details about their families and the family dynamics, and how do you manage matters of privacy and privacy control?
Excellent question. And the answer to that is no, we don't sign NDAs. That has probably not been something that's been in our culture. Having said that, we have pretty strong guidelines within the organization about what we share forward. None of the names we share are the real names. Pictures are only shared with consent. Information is only shared with consent. So, unfortunately, also what happens is because of the kind of social intervention that we're doing, it is not possible always to maintain anonymity. If I want to try and get them a proper water source, I need to go and use their name at the panchayat.
Yeah.
So there, after a while, that control goes. So, but within the team, like even if we're getting a printout of a case study or a case notes, the idea is not to make sure that it's not left lying around where even other people in the team can read it. So those kind of practices are inbuilt, but no, we don't sign an NDA. If caregivers are in conflict, like the husband is in this case, how do you deal with it? So Aparna, also conflict within the family is a very common like in actual steps. Many times, despite psychoeducation, they don't agree with you. Yeah, so this is a much longer thing. We will be taking it up in our communication session because you have a two-part communications. One is basics of communication, one is difficult communication in conflict situations as well as in collusion and angry situations and stuff. So if you don't mind, I will tackle it there, just bearing in mind that there's we're off overtime anyway. Okay, so I think we can stop here, but like I said earlier, use that WhatsApp group, send across questions if you have any. And what we'll do is we'll also, we will share my slide deck, and with Shala's permission, we will also share hers. So those of you who are preparing to make case presentations, this was an excellent template. So please go ahead and use it. And one thing is, yeah, and the Genogram EcoMap, use it to a way that is convenient to you and your teams. It's absolutely fine as long as you're clear in your key how you're using it and everyone else on your team knows how to use it. So thank you. We're 9 minutes over time. I will see you next week or the week after. And in the meanwhile, I hope you have a good rest of the week and weekend. Look after yourselves. See you soon. Thank you very much.
Thank you, Smriti ma'am, for the wonderful presentation. Thank you, Shala, for the detailed presentation. Thank you, everyone, for participating. Lakshmi, are you saying anything? No, I guess. Thank you, everyone, for participating. Let's see you in the next session. Bye.